Assalamu alaikum. The long clinical consultation day. First scenario, Mr. John Smith, 25 years old, presented to the emergency with complaint of fever and malaise for 3 months. Please take history, examine the patient, and address his concerns. You are ready to start?
Yes.
Okay. You
Hello,
can.
I'm Dr.
Yeah, here you go. You can start.
Okay. Hello, I'm Dr. Muhammad, one of the senior house officer in the medical clinic today. May I confirm you are Mr. John Smith and your age and 25 years old?
Yes, I'm Smith. I'm John and I'm 25 years old.
Okay, nice to meet you, Mr. John. We are here to discuss some issue related to your health and examine you and address your concern. Is it all right with you?
Yes, doctor. Thank you.
Okay. Can you tell me more, Mr. John, what about your complaint?
Doctor, I've been having fever and some tiredness for the past 3 months. It's just there. It's not something that really weighs me down. But in the last few weeks, I've noticed that I'm so tired I cannot go to work anymore. So I thought to get it checked.
Okay, I'm sorry for that, Mr. John. Can you said it for me? Did it start suddenly or gradual?
It started gradually over the month. The fever is just there. It's just something. It's just always there throughout the day, and in the last few weeks, I have gotten more tired, and yeah.
Okay. About this fever. This fever at any time of day, at the end of the day, at night, at morning, or all the day?
It's always there, doctor.
All the day. Is it associated with the sweating?
Yes. I've noticed that as well.
Okay. Is it associated about this fatigue? Do you think anything increase this fever?
No.
It relieved by painkiller?
No.
Okay. Do you measure this high temperature?
Well, I've checked it once, a couple of times, and it's always between 37.7. It has never gone beyond 37.7, really.
Okay. And about this tiredness, is it all the day or at the end of the day?
It's always there.
All the day?
Yes.
This tiredness increased by exercise or even when you didn't do any exercise?
It's always there, doctor. I can't even do anything anymore. I just want to lie down in bed.
Okay. Do you, anyone said for you, you are more pale or more than before?
Could you say that again, please?
Do you become pale more than before?
Do I become?
Any pale or...
Could you say that again, please? I'm sorry.
Pale. Did you feel pale or anyone told you are pale?
Okay, I'm not quite sure about that. I'm not sure. I don't know.
Oh, do you have any difficulty of breathing, Mr. John?
No.
Do you have any chest pain?
Any what?
Chest pain.
Chest pain. No chest pain.
Do you have any racing of your heartbeat?
Yes, I've noticed that a couple of times.
What about this? Can you tell me?
Yeah, I've noticed it a couple of times. It comes and goes, but it's not quite disturbing. It's just that occasionally my heart just feel my heart that beats a bit faster. I don't have chest pain and I don't have difficulty with breathing when it comes. But it's just on and off.
Okay. About this racing of your heartbeat, do you seek any medical advice?
No, I was just thinking it would go, so I didn't do anything.
Okay. Do you have any cough?
No cough.
Any lumps or bumps in your body?
No.
Okay. Do you have any dizziness?
I have no experience that, doctor.
Do you have any headache?
Occasional headache. It's just come and go.
Can you tell me more about this headache?
It's been there. It started about the same time I had this fever started, and it's just everywhere. But at the same time, it doesn't really disturb me. When I use paracetamol, it goes away.
With paracetamol, it's relief?
Yes.
Okay. And any specific side of this headache in your or all over the head?
It's everywhere, doctor.
Okay. Do you have any tummy pain?
I have some tummy pain, but it's like I said, it's not something that really bothers me really, but it's just some mild tummy pain.
Do you have any tummy distension?
No tummy distension.
Any difficulty of swallowing?
No.
Any areas of your your back of your eyeball?
No.
Yellowish color. Okay. Do you have any weakness in your body?
I'm just weak everywhere. I'm just tired, just all over my body. Nothing specific, just everywhere.
Any visual disturbance?
No.
Any history of abnormal shaking of your body?
No.
Do you have any joint pain?
I have joint pain in my leg, in my knee,
Both knee or one knee?
both of my knees, and occasionally my ankles and hands.
Okay. Can you score the pain?
I'll give it
Okay.
about 3 over 10, really.
Okay. Do you have any skin rash?
I have rashes on my body, doctor.
Can I have a look?
Yeah, sure. I could show you. Doctor. I'm sending it to the WhatsApp. I'm not quite sure to do it here, so I'm sending it to WhatsApp.
No worries. I will share it here. I pause the time till will be seen by Dr. Mayan.
Okay. Okay. It's into WhatsApp.
Yes, I'm trying to share it here. Dr. Amal, did you see it in the WhatsApp or you cannot? Okay, wait, I'm sharing it in the chat box. Yeah, here you go. You can see it now in the chat box. Okay, I'll restart the timer. Yeah, here you go.
Okay. This rash all over the body, Mr. John?
Yes, it's everywhere.
Okay. When was it started?
It started about the same time with the fever, but it's only gotten worse in 3 weeks ago.
Okay. Is it painful?
No, not painful.
Any itching?
No, not itchy.
Is it oozing?
No.
Anything increase this rash, like
No.
sun exposure?
I've not noticed anything.
Anything relieve this or improve this rash?
I've not noticed anything that does improve it.
Okay. Do you have any past history of long-standing disease, high blood sugar or high blood pressure?
No, I've always been well.
Do you have any past history I should be aware of?
I've always been well, doctor. I've always been well.
Okay. Do you have any family history of long-standing disease?
No.
Do you
That
have
I'm
any
aware
family
of.
history of? Do you have any family history of similar condition?
I don't think so. I'm not aware of anyone that has this.
Okay. Can you show me your medication list?
I'm not on any medication, doctor, except for the routine
over-the-counter-
paracetamol that I use.
Okay. Do you have any allergy to any medication?
No.
Okay. And do you have any? Do you travel recently?
No.
No history of travel.
No.
Okay. Do you have any mouth sores?
No.
Any history of hair falling?
No.
Okay. Can I examine you?
Yeah, sure, doctor. You can.
Okay. I want to check the vital sign of the patient.
Okay. Temperature is 37.7. Pulse rate is 110 beats per minute. Blood pressure is 160. Saturation is 96%.
Okay. I want to check the pulse. Is it regular or irregular?
Is regular.
Okay. Any collapsing pulse?
No.
I want to examine an eye for pallor and jaundice.
Pale. But
Okay.
no
I want to examine the hand for any palmar erythema, Janeway lesion, clubbing, splinter hemorrhage.
Okay, I will send you the image of the hand.
You can send the image.
Yes, I'm sending it, please.
Okay. Dr. Basim, can you? Send it already?
Yeah.
Dr. Basim can share it here.
I've shared it on the WhatsApp.
Already shared, or you shared in the chat box. You can see it down. And put the timer. Seen already?
Okay.
We can resume.
Okay.
Yeah.
Thank you. Yes.
Go ahead.
Yeah, okay. Then I want to examine for raise JVP.
JVP
Any
no
raise?
raised. No.
Okay. Then I want to examine the cardiovascular system for first heart sound, second heart sound, any murmur.
First and second heart sound, pansystolic murmur in the left sternal border.
Okay. I want to palpate for second heart sound in pulmonary area. Any palpable second heart sound?
No, no, no. No,
What about, okay. Any left parasternal heave?
No, no left parasternal heave.
Any thrill?
Any what? Trill, no trill.
Thrill.
Trill.
Any palpable, yes, any palpable thrill?
No valvular trill, except in the left intercostal, in the left fourth intercostal space, left sternal border.
Okay. Okay. Do you have any bibasal cracles?
No.
Any lower limb swelling? Edema?
No.
I want to examine the abdomen. Any organomegaly?
Oh yeah, doctor, I have pain. Pain in the
left side.
Right side, doctor. In the left side. So in the left side. Sorry, I mean to say.
Okay. How many centimeters below the costal margin?
Just about 3 centimeters with a notch.
Okay. What do you do for a living, Miss John?
I'm a teacher.
Okay, it is a nice job. How much does this affect your work and your daily activity?
In the last 2 weeks, I've not been able to go to work.
I'm so sorry for that. We will give you sick leave until complete our workup. Then we will refer you. If anything, we will refer you to occupational health worker to help you in this issue. With whom you are living, Mr. John?
Well, I live with my parents currently. I'm just sharing the house with them.
Are they doing well?
Well, we are doing well. They are good with me.
Are you financially supported, Ms. John?
Well, I've been doing well, not quite bad financially.
Okay. Do you smoke?
Well, I smoke, doctor.
How many cigarettes?
I've been smoking about 10 cigarettes per day in the last 5 years.
Okay, Mr. John, I advise you to stop smoking, as smoking is not good for general health and in your condition. And I will help you by refer you to smoking cessation clinic if you don't mind. Is all right with you?
Yes, doctor, but what do I have now? I think I'm more particular about what I have now,
Yes.
doctor.
What is your concern, Mr. John? After this information took from you an examination, we need to do further further test and imaging to confirm our diagnosis. Most probably, you have some condition called infective endocarditis. It is infection in the lining of the heart. We need to admit you and to do for you further workup in the form of blood test, basic blood test, and we need to do tracing for your heart, tracing of your heartbeat. We need to do for you imaging, chest X-ray, and we need to do for you imaging echo for your heart, and management plan will involve group of doctor, including heart doctor and social worker, occupational health worker, to give you full care and proper plan of management. Do you have any other concern?
Oh, yeah, doctor, I'm just wondering, why do I have this? Why?
Okay. Do you have any past history of surgical operation before I answer your concern? I ask you, do you have any past history of surgical operation?
No, haven't. No.
Okay, this infection, it could be secondary to some bugs in the body, or sometimes it could be viral infection or bacterial infection.
2
So we
minutes
will do
left.
the work. We will do more test, blood test and imaging to search about the cause.
Okay, doctor.
Do you have any other concern?
But why do you want to admit me, doctor? Why?
What?
I know I'm quite weak, but why are you admitting me? I was just thinking you would just give me some treatment and I will go home back to my family.
Okay, we admit you now to give you to check your to do workup, to confirm diagnosis and to give you appropriate management. And we do tracing of your heartbeat. If any urgent thing, you will receive appropriate treatment.
Okay. Will you be giving me some antibiotics?
We will give you painkiller first. If you have any electrolyte, we will give you fluids. We will give you antibiotic after took blood test for you for culture and sensitivity to know what is the type of bugs affect your heart. Is it all right with you?
Okay, it's okay. Thank you, doctor. I'll wait.
Welcome. Do you drink alcohol, Mr. John?
Yes, I take alcohol.
How many per week?
Oh, a bit above what is expected, really.
Okay, I ask you to modify your alcohol as it may worsen your condition.
Okay, doctor.
Okay, thank you.
You're welcome. Thank you so much.
Okay, almost time is up. Any question you want to add, Dr. Amal, before examiner question? Any examination you want to do? Even to offer examination? To examine something? Using a tool?
We will do basic investigation, or we'll
No,
do
not investigation. No, not investigation. Now you're in front of the patient. You want to do or offer examination? Offer to examine something?
No.
Fundoscopy?
Fundoscopy.
Do you need?
Yes. Yes.
Okay. Searching for? Looking for? Dr. Amal?
Fundoscopy, look for hemorrhage. I forget the name.
Yeah.
Retinal.
Roth spots, right? Okay.
Yes.
Time is up. Now the examiner question, Dr. Ayula, please go ahead.
Thank you, doctor. So, okay, what would you say this patient had? Can you summarize this patient?
Okay, this is 25 years old male, complain of fever and tiredness for the last 3 months. And also there is skin rash all over the body. On examination, she had roses. She had palmar erythema and splinter hemorrhage. He had Osler's node, and in the heart she had pansystolic murmur. She had also tachycardia and regular pulse. That is all. Yani,
what do you think? You mentioned this patient has infective endocarditis. Is that right? So what are the other differentials?
Fever and tiredness. It could be lymphoma, but no signs, no symptom and signs suggestive that. It could be any infection, tuberculosis, malaria, HIV. I didn't ask. I forget to ask about risk factor for HIV.
Okay. Any other differentials?
Other differential.
Okay. Why do you think this patient has infective endocarditis?
This patient had fever, tiredness, and he had Osler node.
I mean,
He
in terms
had
of risk factor.
risk factor.
Yes.
I didn't ask about IV drug user.
Okay, so
Recreational
what
drug.
are the risk factors you will have been looking for?
Risk factor يعني any prosthetic valve, any IV drug user, any sharing needle.
Okay. Any previous maybe some dental work in the past, okay? Background valvular diseases could be something that we could look out for. HIV, like you said, okay? What are the diagnosis? What is the diagnosis criteria for infective endocarditis?
Diagnostic criteria. والله I forget بس في major criteria, minor criteria. I think arthritis, carditis, chorea.
Okay. What's the name of the criteria? Do you know the name of the criteria?
Fever, high SR, joint pain.
Okay.
Forget. Okay.
Yeah, all right, doctor. I'm not well. The name of the criteria is modified stroke. Okay, I think we'll talk about that during the student discussion. Okay, and what do you see this patient has any complication?
Yes. In this case, or all.
In this case, is there? Did you identify any complication?
Yes. This murmur. This murmur. That means there is valvular affection.
Okay. So, what complication will I be looking out for?
We look for we will do for the patient ECG. Look for BR prolongation. Prolongation. This may be aortic root abscess, and this needs surgical treatment.
Okay. Thank you. Will you be giving will you be giving antibiotics?
We will give antibiotic after took 3 samples for blood culture. Then we will start antibiotic.
Okay, and how long will you give antibiotics for if you want to?
It is different if it is native valve or prosthetic valve. I think for 6 weeks. If it is flocloxacillin and gentamicin for 6 weeks if it is native valve.
Okay.
And maybe I'm not sure if maybe prolonged for prosthetic valve, but we use another antibiotic like vancomycin, gentamicin, rifampicin.
All right. Thank you so much. I don't have any other question. Thank you. Well done.
Thank you.
Okay, thank you, Dr. Ayula, Dr. Amal. Well done. Now the comment, Dr. Ayula, then I will comment.
Okay, all right. Well done. It was a good presentation. The history, you took a couple of history about the fever, and you were, I like the way you talked about try to find the timing of this fever. But one of these things I think we might want to look at in the history is for what I'm not quite sure at what point you knew this was infective endocarditis, but I think identifying the risk factor will have been a big thing in this patient. Okay, if you have asked me if I use IV drug, I will have said yes. Okay, and the complication, I was not quite sure you were looking out for the complications of infective endocarditis. Urinary output, if I'm still passing urine, any blood in my urine, I'm not any blood in the urine. You talked about palpitation, which might be looking out for if there's any form of emboli in the heart. Okay, seeing rashes on the body also means that possibly the patient has also through some emboli everywhere, which could include the kidneys, the brain. So you have to look out for features of that patient have any weakness. So I think you might mention that any partial weakness anywhere as well. You did spoke about vision. Yes, I remember that. So basically, that is it. And because the momo is in the left sternal border, that is likely to be a tricuspid valve involvement, which is not quite common in investigative. Most common is in the mitral, and I think the mitral valve is common for infective endocarditis. Picking a momo in the left sternal border would point to that it's likely to be a tricuspid valve involvement, and that should pick our mind back to that there's possibly a system, some form of IV drug usage that might be predisposing this individual to the right side heart involvement, because it's common in the left side. Okay. Another thing that I want to point out here is the diagnosis criteria. It's called modified Dukes. I think you were trying to say that for what do they call it? Rheumatic arthritis fever. That's the one you were trying to rheumatic heart disease. Sorry, that's when you're trying to mention about the carditis, rheumatoid migraine, and the arthritis. For infected carditis, it's called modified Duke, and it is doing blood culture, having identified specific it has 2 major criteria and 5 minor criteria. Okay, and I believe if you picked 1 major criteria and 2 major criteria, you can confirm the diagnosis. 1 major criteria or 2 plus 2 minor criteria, you can make the diagnosis, or all the 5 criteria, you can make the diagnosis of infective endocarditis. And of course, like you okay, for the differentials, we could look at the possibility of lymphoma in this patient, though there is no lymph node enlargement. Okay, systemic inflammatory diseases like SLA can be a good differential because of the rash, the fever, the malaise that this individual is having. Though is a male, but it's most common in female, but of course it can also happen in male. Those are the things that I can point to. And also indication for surgery in infective endocarditis. I can't remember it at heart now, but I know there's indication, the size of the of the and I am not responding to antibiotics, the size of the I can't remember at heart now, indication for surgery in infective endocarditis. Okay, that is my comments. Thank you.
Yeah, well done. Perfect. Thank you, Dr. Ayola. Good preparation and good presentation as well for the case. Excuse me, Dr. Amal, please prepare a case for Dr. Ayola. I will comment through this time. You can arrange another case. Okay, so well done. Initially, you got the case, but you missed 2 important things. At any presentation, you have to know what are the complication, the association, and the underlying pathology. You missed, I think, the risk factor, which is underlying pathology. Why this patient in such age is having infective endocarditis? It's not usual, right?
Mm.
Not every person who's healthy one, he will get infective endocarditis. He should have risk factor. So you have to analyze for the risk factor. You got the case earlier, but you didn't screen for the cause, which are, as you said, the HIV. All question for HIV you have to ask, starting from drug abuser, recreational drugs, sharing needles, tattooing. All this can lead to the infective endocarditis as a precipitating factor. Adding to the procedure or surgery, you ask about the surgery, but you didn't ask about procedure by name. Some patient will tell you, no, I don't have any surgery. But when you specify any procedure or dental procedure particularly, he will tell you, yes, I have done some dental extraction last week or prior to this manifestation. Okay, so this is the second possible leading factor or precipitating factor. The third possible cause will be sexual history. You have to take full HIV question or the sexual history questions. So I'm so sorry for this question. Do you have any casual relationships or you have regular partner? Yes, I have. Any casual relationships? Then is it protected or no? To rule out HIV, and HIV itself one of the causes of or underlying pathology of infective endocarditis, immunocompromised patient. So you have to know what are the risk factor for such condition in such age while he was healthy person. What other manifestation you missed, as Dr. Ayula said? You missed the renal complication. You didn't ask about the renal system at all. Any change of the water work, he might pass some blood. Hematuria is in one of the manifestation. The other manifestation which you didn't ask, I think the visual, you ask about the visual, right? So you have to specify any visual problem or vision problems. These are for Roth spot, plus the examination, as I remind you at the end. But it's okay to ask, at least to offer to do the ophthalmoscopy or fundoscopy examination. Let's go back step, how to take history without missing those things. So for the fever, as one of the constitutional symptoms, it's one of the constitutional symptoms or system questions, right? Fever, night sweat, lumps or bumps, loss of weight, loss of appetite. After analyzing the fever, good question you ask about the fever. When it started, is it regular or cyclic? You have to ask particularly for malaria, cyclical fever. Is it on and off in regular timing? Every 48 hours, every 2 hours, every 48 hours or every 2 days. These or this is characteristic for malaria. But the other question was good. The timing, what increase, what decrease, and what associated with. Okay, so this is the analysis, onset course, duration, timing. Always remember all these items, onset course, duration, timing. Then the associated symptom, which was malaise, the weakness. I cannot cope with my daily activity. I cannot. I wanted you to be more sympathetic. You didn't tell him even, I'm so sorry for your feeling, for your suffering. Once he said to you, I don't have any power even to do my daily activity. Okay, so these are or this is important, very important to show the examiner that you have some sympathy for his suffering, because this patient is having fever for 3 months at or recently. He shouldn't do anything even at home. So you have to show him more sympathy and empathy, okay? Back to the history taking. After analysis, onset, course, duration, my approach, which I prefer in any long clinical consultation. You finish all these analysis. Now you will go to the relevant system. Here, I believe the constitutional symptoms or system question is related to this patient or relevant. So you will ask about loss of weight, loss of appetite, night sweat. Already there is fever. If you got more finding of constitutional symptoms, so you have either HIV, infective endocarditis, or cancer. Great, great. Now the next system or the next question, you will ask about past medical history, and not only medical. Past history related to the medicine means medical, surgical, allergy, herbal, procedure. Why? Because you are going to prescribe medication for this patient, antibiotics particularly. If he has any allergy, you will be in trouble. Please ask those questions in package. Okay. After finishing this question, either to have the risk factor or at least to know the clue what this patient is having. The next thing is systematic or systemic review. According to your differential diagnosis, any patient with fever, the most common cause or the most common system affected or infected to be having fever, as we know in cases, on the top of them, meningitis, right? From the CNS, I mean from head to toe. Started from the head, there is possibility to be meningitis, right? So you have to ask about neck stiffness. She told you I have headache. Once you have headache, alarming fever, you have to ask about the neck stiffness. If this patient is having neck stiffness, you will miss meningitis. So what are the system could be infected and the patient will have fever. The first from the CNS meningitis. The second, cases wise, I'm talking. So we'll not talk about orbital cellulitis. Yes, it's one of the possible, but it's not common in cases. But still, you can think about if the patient is having swelling in the eyes. But I'm talking about the most common cause of fever related infection in cases. Started from the CNS meningitis, the second system, chest, right? So the patient will have cough or coughing up blood or dyspnea or whatever any respiratory symptoms. So this is the second system could be infected. I mean any inlet or any area the organism can invade, so you can suspect infection related. The second system from up down, it would be the chest. The second or the third, cardiovascular, heart, rheumatic fever. Basis wise, I'm talking. Okay. Next, the abdomen, GI, gastroenteritis, whatever the reason. Next, the renal or genitourinary, UTI. You'll talk about all causes of the pyelonephritis or even some stones or even urethritis or even related to reactive arthritis after having sexual contact, whatever the reason, but still the system would be affected is the renal system. Then the musculoskeletal skin, some skin infection. Yes, there is possibility, but it's not common in cases. The joint infection, reactive arthritis, or the septic arthritis. It's there in the cases and common as septic arthritis topic. So your differential will be for one of these five systems I mentioned. It started from the head, meningitis. The respiratory will be chest infection or pneumonia. The next will be infective endocarditis in the heart, cardiovascular. The abdomen will be gastroenteritis, genitourinary, pyelonephritis or UTI, simple UTI. Add more the joint, septic arthritis, or fever of unknown origin. You will get it from constitutional symptoms, cancer or connective tissue disease, or like chronic fatigue syndrome, patient with prolonged fatigue and weakness. So he would be presented with low-grade fever on and off for a long time, more than 6 months. This is another topic, but we are talking about infection, and PACES would be one of these systems. Okay? Back to the systemic review. Every question in the systemic review will guide you. If you have headache, blurring of vision, signs of increase in intraocular pressure, so you will suspect meningitis, neck stiffness, meningitis. Next system, patient cannot breathe well, short of breath, coughing more, sputum, colored sputum or uncolored, whitish, whatever. So this is just infection. Here in our case, it was blood and cardiovascular heart examination or heart infection or valve infection, so infective endocarditis. The next system will be the abdomen. Any change, any discomfort? Yes, there is splenomegaly. It's one of the manifestation or complication. The renal system, any change of water work? Yes, there is hematuria. You have to ask system by system, maximum two questions in every system. But try to make the question make sense. So in the renal system question, you will ask about any blood in urine. It's one of the possibility, right? Any skin rash, which is very important, and I think it was the clue for you to got the case. All the manifestation of infective cardiac the skin you have seen in this patient. You can present it or you can present them in the presentation. The social history, travel is very important here. Don't forget travel. By the way, I missed the hepatic system, one of the GI system, which can also come in phases, hepatitis A or hepatitis C, but you will have jaundice, you will have dizziness, you will have distension, you will have ascites. So you will have another GI manifestation. Back to the social, family history, travel history, HIV, sexual history, and recreational drugs, risk factor. Then do you smoke? Do you drive? Do you drink alcohol? What's your job? Then start to examine the patient. I think the examination and the history taking was perfect by Dr. Amal. Apart from the renal system, you miss the renal system, you miss other constitutional symptoms, which is loss of weight, loss of appetite. Okay, because you can put HIV one of the differential examination, you miss also lymph node examination and ophthalmoscopy for spot. Otherwise, you did great. The question also you answer well, but please don't use more jargon and more investigation to the patient. He doesn't need to know about his investigation. I will do culture for you. No need to mention. I will do some blood work up for you, and after the result, I will tell you or I will update you about your management plan. You are not sure about the diagnosis. You want to know what the possible diagnosis? Yes, you can tell it's infective enterocolitis. Have you ever heard about it? No, it's one of the infection in your blood and your heart gate. It might be related to some risk factor. Of course, if you discover it, you can tell him because of your risk factor. It might be related to the, for example, drug abuse or using or sharing needles. By the way, one of the examination you have to do here, injection mark. You don't know till now, Dr. Ayula didn't tell us if this patient drug abuser or no. But if you want to examine, you have to examine the cubital area for injection mark, the inguinal area for, again, the groin, I mean, for injection mark, along with the lymph node. Okay, infective endocarditis as a topic is very important. It can come as long clinical consultation or sometimes as a murmur in cardiovascular station. The doc criteria, as Dr. Ayula mentioned, two major criteria or one major plus three minor or five minors. The two major criteria, echo finding or blood culture, typical for infective endocarditis, or the minor criteria, fever, or the other blood culture, or vasculitis manifestation, hematuria, Ross spot, ossular nodes, or splinter hemorrhage. All these are the minor criteria. Don't forget to refer the patient to multidisciplinary team approach, including the heart doctor or cardiologist if you are talking to the examiner, infectious disease, notification, of course, you have to notify, and the antibiotics, as Dr. Mayula said, long time, and it would be IV or medication through your blood channel. So no chance to be discharged. Don't give him any hope to be discharged because this patient might present with heart failure later on. Okay, so you will be admitted. One of the decision, medical decision, he will be admitted and he will be given medication through his blood channel, IV medication, and after the blood culture, we can narrowing the antibiotics. And you can mention to the examiner according to the valve nature, is it native valve or prosthetic valve? Since this patient, of course, doesn't have surgery, so will not be having prosthetic valve unless he has it or he had it earlier as rheumatic heart disease replaced by, for example, and I don't think there is a replacement by catheterization. So it would be by open heart or cardiothoracic surgery. So he will tell you, I have a surgery before, or I had a surgery before with replaced valve. Any question or missed point? Anyone to add any point? Please go ahead. Feel free to comment. It's not restricted meeting. Only me to comment. You can comment. Any question? Of course, the all comment I read was correct. You have to screen for risk factor, Dr. Amal. Okay. Okay. The last question, Dr. Saman. What was the diagnosis differential? Diagnosis is infective endocarditis. The differential, as Dr. Ayula said, you have to mention the HIV because HIV might have also complication as infective endocarditis, and its risk factor for infective endocarditis plus the connective tissue disease or Liebman sac endocarditis as a complication of SLE, but you can't say against that. Okay. Any other question? Brucellosis, Dr. Sarah. Brucellosis will have other manifestation like back pain, risk factor for farmer, so it's different in presentation. Abscess in brain, you cannot say abscess in brain. Yeah, you mean as a complication. Yes, you're right. If the patient is he's showering or the valve is showering, yes, it might be spread all over the body, going to the brain, going especially if the valve affected it in the left side. You can mention this one of the complication. Meningitis, general symptoms, then cardiovascular and CNS should be asked thoroughly. Yes, I agree. Yeah, okay. Dr. Ayula, your patient, 33-year-old female, complain of weight gain for 6 months. Please examine, take history, and address the concern. Okay, now the mic is open. If no one will comment, we can start the second case. Anyone want to comment, please go ahead.
Dr. Basim,
Yes, sure.
sorry, Dr. Mohammed.
No.
The type of rash showing up in the picture, the maculopapular rash over the back, it looks like salmon-colored pink rash, which is most likely typical of adult onset Still's
Yeah.
disease.
Yeah.
So, and if it is not, then it could be also a DD.
I
I
agree
was
with you. Yeah, I agree with you. It's not conclusive for infective carditis, by the way. The most specific here was splinter hemorrhage and the Janeway lesion and Osler nodes. So it's
Yes.
not conclusive. The skin rash over the back, it's not conclusive. But
Okay.
meningitis can present with any rash as a septic focus, right?
Yes.
Yeah, otherwise it's not conclusive. You cannot say this is because of meningitis. Oh, sorry, because of infective endocarditis. But you can say or you can conclude that the lesions in the hands is characteristic finding of infective endocarditis. Plus, of course, the murmur, Dr. Amal, you have to specify or you have to pick up the murmur. You have to have a murmur in this patient, either right side or left side, according to the valve infected. Mostly, it would be the tricuspid, as this patient maybe he is drug abuser. Okay. And what is the most common organism in infective endocarditis, Dr. Amal?
Staph aureus nowadays.
Sorry?
Staph aureus nowadays.
Staph aureus as drug abuser. Yes, you're right.
The
But in
HINA new
general,
guideline all over is Staph aureus.
really, I'm not sure about this update. If you have this update, please share it with us.
Yes.
Okay.
Dr. Basim, Assalamu alaikum.
Walaikum salam. Yes. Yes, it
I
was.
want to ask about the first picture and
Yeah.
the dorsum of the finger. What is the characteristic lesion here? Not in the palm, the dorsum of this finger.
I guess it was
Nothing?
splinter hemorrhage, right? Wait, I'm looking for it.
At the dorsum of the finger is splinter hemorrhage or in
Yeah,
the palm?
splinter hemorrhage related to the nail,
The name is
right?
Yes.
it may be Osler node.
Osler node, yes. Osler node at the back, dorsum, and the genway on the palm.
Mm-hmm.
And which is
Thanks.
painful? Which is painful, you know?
I think the Osler node.
Yeah,
Osler node, I think.
exactly. Remember O for ouch, so it's painful. O for ouch mean I have pain, ouch pain, right? So O for ouch, painful, Osler nodes. Okay. Palpitation, fever, yes, of course, Dr. Amal. Any cardiac symptoms you have to pick up in this case. Tachycardia, and you have to ask, by the way, you have to ask about the regularity. Do you feel it regular? If he said, what you mean, doctor, you can tap on the table. Okay. But you can also do it as examination of the pulse later on. in the examination step. So you can examine for the pulse, you can say it's regular or irregular, the pulse volume, the collapsibility. You have to comment on all of this. Dr. Sarah Bashir, a lot of comments. I think I miss a lot of comments. Atrial myxoma. Yes, atrial myxoma as a cause of murmur, but it can lead to the same finding, or you can put it as a differential. I don't know. I'm not sure. It could be, but it's a differential for mitral stenosis, by the way. You can say it as a differential of mitral stenosis, but not in this case, I think. So it's a cause of clubbing as well, yes. But this patient doesn't have clubbing. Unless this patient is having clubbing, you can say, yes, there is murmur, there is clubbing, so I can put atrial myxoma, particularly if there is mid-diastolic murmur. So
Because
you
of the
can,
constitutional symptoms also.
yeah, it can lead to, yes, you're right. Yeah, somehow it can be, but it's not the common differential in this case. So you cannot say atrial myxoma as second differential. No, you have to say, for example, HIV first before saying the atrial myxoma, right? So HIV as a common differential better or prior to the atrial myxoma as a common differential. So try to mention always the common differential, not this the thing will be unique. Don't try to be unique in your differential. They are not looking for the who's the giving me the unique differential. No, they are searching for who's giving the common differential. Because you are looking for the common disease first before thinking about the less common. Okay.
I think she should ask about sore throat or any recent illnesses or these illnesses in the.
Yeah, she asked about, but she didn't specify for dental. She asked about surgery, but she didn't specify for dental extraction or dental procedure. It's the trigger here. I think this is the cause, not IV abuse. So it's important to ask particularly about dental, even Dr. Amal, even at the end of your taking history, and you
No, I'm talking about rheumatic fever as the cause of the infective endocarditis. She should dig about the history in the past about
she
sore
asked.
throat, recurrent
You mean
tonsillitis. Yes.
earlier, yes. But at least you have to ask about surgery, and if there is possibility, the patient would have surgery, which is open heart for valve replacement, and he will say it clearly, I think. So she asked about surgery, but she didn't ask about the manifestation of heart disease. But she asked good question for the family history. Although it was negative, she asked him if you have any family history of same condition, related condition, or something in the families, running in families, which is a good question. So you have to screen for the family, particularly if you have unexplained disease. Yeah, Dr. Muhammad Omar wrote the indication for surgery. I agree. You can even give three of them. Try to memorize. The most common is resistant. You are trying to treat, but the patient is not improving, or atypical organism, or aortic root abscess. As Dr. Muhammad, you can see in the chat box. Multiple septic emboli, of course. Heart failure, yes, one of the also indications. Okay, so resistant of any medication or resistant to medication in any disease is an indication to have interaction, further interaction, which is surgical interaction. Okay, or surgical intervention. We can start now the second case. Dr. Ayola, you ready? Any question before moving on? Okay, Dr. Ayola, ready?
Yes, I am.
Oh, I already start the timer. Yeah, here you go.
Mm. Hello, just a second. What was the name of this patient? Sorry, I'm just trying to. I didn't get it. Can you read the question, please?
Yeah, it was no name, so you can say
هنا يلا.
Julia or who's any name. Julia Smith, okay? Julia Smith.
Okay. Sorry, can you read the question? I can't access the chat. That's the concern. That's my. I don't know what's going on. I can't see the chat. Okay, I've seen it. Okay, I've
Patient
seen
will
it.
present with gain weight or weight gain.
Okay, all right. Okay, thank you. Can I start now?
Yes, here you go.
Yeah, hi, hello.
Hello?
Yeah, I'm Dr. Ayola. I'm one of the doctors here today. Can I confirm you are Mary James, 33 years old?
Yes.
All right. Is it okay if I call you Mary?
Yes, doctor.
Hi, Mary. I understand that you are here to see us because you have some complaint. May I know your complaint, please?
Yes, doctor. I have my weight increased in the last 6 months, and I have stress for that.
Oh, there I can see that you've been having some form of stress with this weight gain. Let's have a chat and see if there's a way that we can arrive at what is causing this and possibly have a management plan for you. Is that okay?
Okay, thank you.
Yeah, could you tell me more about this weight gain? When you said it started 6 months ago, right?
Yes,
Is there any part of your body that you notice that you are gaining weight more, or it's just everywhere?
all the body increase in the weight, and
No.
I didn't concentrate.
Okay. All right. And since it started, has it been progressive? Has it been getting worse
Yes, doctor, increasing all the time.
all the time? Okay. And okay. And it's everywhere in your body, you said?
Yes, I didn't concentrate, but everybody said for me, you are gaining weight, gaining weight.
And have you checked your weight at any time?
What?
Have you checked your weight at any time? Have you checked your weight?
Picture?
Check the weight. Do you know what your current weight is?
Yes. I check my weight. Now my weight 100 kilogram.
And what was your weight before in the last 6 months? Before this time?
90.
90 kg. Okay, so you've gained 10 kg in the last 6 months.
More than 10 years.
Okay, all right. And how is your appetite? Is there any change in your appetite?
No, doctor.
Okay, and could you tell me about your activity? What was your activity like, Mary?
My activity is the same, but I have some fatigue.
Okay, okay, sorry about the fatigue. I mean, have you increased have you, as your activities reduced? What could you tell me do you exercise?
I do exercise like before, but
Okay.
when I try to do my activity, I feel some fatigue, especially when I combing my hair or get up from the chair.
Okay, all right. Thank you for that information. It's quite helpful. And how long has it started?
It started 4 months ago, this fatigue.
Okay, all right. And it's worsened. And when you want to comb your hair, you couldn't do that. Is that what you mean?
I feel tired.
You feel tired at all time. Okay. Have you got any rashes on your body?
No, doctor.
Have you noticed that you are sweating more or less these days?
No.
Okay. Any fever? Any temperature?
No, doctor.
Okay. And how is your vision like? Any
Vision?
concern about your vision?
No, doctor.
Have you got any headache?
Headache? Sometimes I have headache.
Okay, could you tell me about this headache, please?
All over my body.
All over the head, all over the head, right? Is it dull aching?
It is aching dull.
Okay. Does paracetamol relieve the headache?
Yes, sometimes without medication, really, and sometimes with paracetamol.
Okay. Any neck pain, Mary?
No.
Okay. Any neck swelling?
No.
Okay. Have you got any darkening of your body in any part? Any darkening of your body? Any skin rashes on your body?
No skin rash.
No skin rash. Okay. Any tummy pain?
No.
Okay. And how is your bowel like? Are you passing by? Is your bowel like?
What?
Your bowels. Are you going to the toilet well? Poo.
Yes, normal.
It's normal. Okay. What about your urine? Any concern about your urine?
No,
Okay. And any chest pain?
no, doctor.
Okay. Any shortness of breath?
No.
All right. Have you noticed that your hair is falling? Your
Any
hairs are
what?
falling. Your hairs, are they falling? I mean, are you losing your hair?
My hair?
Yes, hair. Are you losing it? Mm,
Um,
Loss of hair.
minimum. Yes, minimum loss, mild loss.
Okay, all right. And have you noticed any dry skin?
Dry skin, no dry skin.
No dry skin. Okay. Just a big question about your general health, Mary. Have you mind for any medical condition?
Doctor, I have high blood sugar for the last 3 months.
Okay. And is it well controlled?
I try to control it.
Okay. And what are you using for that?
I use some drug called metformin.
Metformin. Okay. And when was the last time you checked?
Last time I checked before 2 months.
What was it?
I don't remember.
Okay, all right, thank you. Have you got any dizziness?
No.
Any weakness in any part of your body? Any differential weakness in any part of your body?
Weakness?
Yes, in any part of your body.
No weakness, but I said for you, when I want to get up from the chair, I feel very weak, very difficult.
Okay, all right. What about your blood pressure? Any concern about your blood pressure?
I didn't seek medical advice before last 2 months. I don't know about my blood pressure.
Not to worry, we'll check it before you go today, okay? Before the end of the conversation today, okay?
Yes.
All right. Could you tell me about your it might be a little bit intrusive, okay, Mary? But it's just a question that I need to ask. Could you tell me about your menstrual period?
What you want to know?
Okay. When was how is the menstrual period like? Has there been any change in the quantity? I mean, has the volume of your menstrual period increased?
Yes, my period is irregular. Sometimes more, sometimes less. Sometimes 3 months not go, and sometimes come every 21 days.
Okay. And when was the first time you noticed your first period?
First time
Yes, the first period. When was that?
when I am 16 years old.
16 years old, and it has been regular until has it been regular since, has it been like this since then?
What?
I mean, when did you notice that it become irregular?
Yes, this is for the last 6 months.
The last 6 months as well. Have you ever been pregnant, Mary?
No, I'm not pregnant.
Okay, are you trying to do that?
No.
Okay, you are not actively trying to get pregnant. Okay, could you tell me about any family history of similar?
I have a kid.
You have kids. Okay, all right. How many kids do you have, if you don't mind?
Two child.
Okay, children. Okay, thank you for that information. Okay, do you have any family history of similar condition?
No, doctor.
Okay,
No,
and
doctor.
have you had any surgery before?
No.
Okay, are you on medication? Any medication like steroid? Have you heard about that before?
Steroid?
Yes.
Tabs?
Tablet, any tablet like that? Does that sound familiar to you? Any medication like steroids?
No, I didn't took tabs called steroid.
You did or you didn't?
What?
Did you say you did or you didn't? I didn't get that.
No, I didn't took any medication called steroid in the tabs for.
Okay, and are you on any medication at all? Any other medication?
No, I took only some cream.
Okay, could you tell me what the cream is, please? Do you know?
I forget this name.
Okay, do you have the list with you? Do you have the list of the drug with medication with you? The cream?
The cream,
Mm.
I forget this name, but I
Oh.
took metformin for high blood sugar only.
Okay, all right. Thank you for that. Okay. Do you take alcohol, Mary?
What?
Alcohol. Do you take alcohol?
Alcohol? No.
Okay. And do you smoke?
I smoke 1 to 2 cigarettes per day.
Okay. And have you ever considered quitting smoking?
Yes, doctor.
Okay, that's cool. That's quite impressive. Well done. If you at any time need any assistance, we could render you some. Is that okay, Mary?
Okay.
All right. Who do you live with at home?
With my husband and kids.
All right, good. And what do you do for a job?
I'm housewife.
Okay. And how has this affected you? The tiredness, I know it can be sometimes worrying. How has it affected you?
Yes, I feel tired most of the time and affect my daily activity, my house job, and taking care of my child.
Okay. Oh, I see. We could see where we could address this. Okay.
Okay.
All right. Have you got any allergy?
Allergy, no?
No allergy. Okay. All right. Mary, have you got any concern today?
Yes, what happened for me? I want to know what I have.
Okay. Mary, there are a couple of things that is going through my mind that might be what is going on. But before we proceed to this discussion, is it okay if I examine you?
Okay, doctor.
Okay, all right. I want to look at you, check if there's any rash on the body or any skin changes. Okay, check your armpit, check your if there's any check the neck if there's any changes, any skin changes.
There is a thin skin in the hands and the forearm.
There is what?
Thin skin. Thin skin.
Thin skin. Okay, all right. Thank you. Is it dry?
No.
Okay, so I will check the pulse rates, the pulse pressure.
Pulse rate 90 beats per minute. Blood
Is it
pressure
regular?
100. Regular.
What's the
Blood
pulse pressure?
Blood pressure 145/93.
Okay, is it any collapse? Is it collapsing?
No.
Okay, so I'll go ahead to check your weight against your height.
Yes, body mass index 30.
So I didn't get that, please.
What?
What's the body mass index?
30.
Okay, all right. Thank you.
Welcome.
Thank you for that. I'll examine your the chest as well. See if there is any looking for any murmurs. Anything in the chest? No.
Just clear. No,
Not
nothing
scared.
in
Okay.
the
Also, I also check the visual field as well.
visual field normal.
Visual field normal. Okay. Thank you.
2 minutes left.
Thank you for allowing me to examine you, Miss Mary. Okay. From all that we have discussed, and from this, I know you're quite concerned about what has been going on. And I've told me that you've gained some weight in the past couple of months, and other history that you've told me, and your examination findings. I'm suspecting that you may have a condition that is called Cushing syndrome. Have you heard about that before?
No, doctor. What is this?
Okay, it's just is a condition in which there is abnormal production of a particular protein in the body. Okay. By the way, that may be causing the body to produce more. That may be causing the body to retain more fluid. Okay, and it may be the reason why you are having the recent diabetes that you said was diagnosed, and the blood pressure that is also high. But not to worry, we will evaluate you more to establish this diagnosis by doing some blood tests for you, some special blood tests, routine blood tests and special blood tests to be able to arrive at this diagnosis. Mary, are you with me?
Yes, doctor. Do you think, doctor, these creams I use is a cause of this disease?
Do I think what?
These creams I use some creams for a long time.
Yes, possibly, because I would have loved to see the cream, but since you are not with the cream, if it's something that you can bring in the next appointment, we could have a look at it and see what exactly it is. But it's a possibility that this can be, but sometimes it just occurs on its own. We don't have a reason for it, but it could be the reason as well. So when you come next time, we can have a discussion about that, okay? By the way, Mary, are you coughing?
What, doctor?
Do you have any other concern?
No, doctor, thank you.
Okay,
All right.
time is up. Examine your question, please. Dr. Amal, you can start examine your question now.
Okay, summarize your case, doctor.
You said?
Present your
Summarize.
case.
Okay. This is, I've just examined this. I've just spoken to this young lady who presented with 6-month history of weight loss and recently, was weight gain, sorry, and recently diagnosed diabetic, of type 2 diabetes mellitus. On examination, I found his body mass index is elevated, which further confirmed that she probably has been gaining weight. And also blood pressure is elevated. And I would also love to check the random blood glucose now to see what exactly the blood glucose is right now. It also has thin skin and also has proximal myopathy, which I would have loved to further examine if I have more time to do this. So some weakness in the upper limb and so weakness in combing his hair and climbing the stairs, which I think might be proximal myopathy, and I want to further examine this. Putting all things together, I'm thinking that this patient might have Cushing syndrome, and other possibility could be polycystic ovarian disease in this lady. Thank you.
What is your other differential? You mean Cushing syndrome, polycystic ovary syndrome, then what?
Polycystic ovarian syndrome, Cushing disease, and also hypothyroidism.
Hypothyroidism. Do you have any other differential?
Well, medication use as well could be a drug-induced side effect of medication. It can also be side effect of medication.
Okay. What you want to do for this patient? What is the plan of management?
For this case patient, I want to do routine blood tests for her. It will include the kidney function test to check for the electrolytes, and also do a random blood glucose for her to see what the glucose is, and also make specific diagnosis. I want to do cortisol level, early morning cortisol level, 24 hours cortisol measurement. Depending on if this suspect is suspected, I'll go ahead to do a dynamic test for this patient to do a dexamethasone suppression test for her, which will further make a diagnosis further confirm my diagnosis. I also want to do some imaging to include the cranial MRI, and also to cranial MRI for her, and also to check the cranial MRI for her as well. Yeah. Thank you. And in terms of management, depending on what the diagnosis is, depending on what the diagnosis is, if I'm able to confirm this diagnosis, I would want to manage this patient appropriately. First, by referring her to the multidisciplinary team, where she will be further discussed, and then if she will further discussed, and then manage other risk factors that she's having, manage the blood pressure, and also the diabetes mellitus, diabetes mellitus that she is having. Thank you.
Okay, thank you, doctor.
Still 1 minute.
Also,
yeah.
Okay, yeah.
Continue, Dr. Ayula. There's still 1 minute 15 seconds. You can add further management plan.
Okay, and also if there is need for, depending on the cause of the Cushing syndrome, we could go ahead to give her some medication to help with this, to block the production of the Cushing syndrome, the cortisol hormone, and also if surgery is indicated, we could also do, and also Radiation therapy can also be considered. And if any causes is identified like medication, we want to stop this medication first. To also want to stop this medication first. Yeah.
Okay, doctor, thank you very much. You are well.
So I have question. Would you stop the medication by yourself?
Oh no, I wouldn't want to do this. We will refer
Yeah.
our endocrinology team.
Yeah. Okay. If you suspect extra cause of Cushing, drug induced, do you think you can stop the medication abruptly? Is it
No.
wise? So what you
No,
will
we
do?
taper the dose because of the risks of sudden drop in the in the steroid and endogenous production of steroid, which can lead to Addison disease.
Perfect. Medicinal crisis. Yes. One more question. What's the management, the pharmacological option you can give to Cushing syndrome?
For
The
Cushing
name.
syndrome, we could do some ketoconazole.
Perfect. Yes, ketoconazole. And metharopone.
Okay, metharopone.
Yeah, and according to the cause, right? You will treat the cause either by if Cushing syndrome, so you can give the pharmacological option. If there is adenoma,
Okay, yeah.
what you will do? The options?
Surgery.
Yeah, so you can do a surgery. But first of all, it's multidisciplinary team approach. Thank you, Dr. Ayula. Well done. Let's hear Dr. Amal comment, and I will comment. Dr.
Okay,
Amal,
Dr.
please.
Amal. Well done, Dora. You forget something in the history. يعني differential diagnosis of weight gain should be divided into endocrine cause and maybe salt and water retention. So you want to exclude the endocrine causes and these other causes like chronic liver disease, chronic kidney disease, nephrotic syndrome, congestive heart failure, and drug-induced you are excluded. Then in the differential, you can include insulinoma. You ask about, you have to ask about fainting attack, low glucose level measure before, sweating, like that. Then you have to involve metabolic syndrome in the differential. The patient had high blood sugar and high blood glucose. Okay. Then in examination, you did good examination, but you have to search about the site of weight gain. Yeah, you have to look between scapulae, behind the neck for buffalo hump, like that. Then you have to examine the abdomen for any striae, like that. Then خلاص باقي good الحمد لله.
Yeah, thank you, Dr. Amal. Well, good case and common case as well.
Yes, I forget something,
Yeah,
doctor.
sure.
In the Cushing, also you have to ask about back pain and joint pain. Some of complications can cause osteopenia. And you have to examine the back for any tenderness.
For osteoporosis, yes. Yeah, okay. Thank you, Dr. Amal. Nice case and common case. Cushing, I think both scenarios today is very high yield topic in the exam. The infective endocarditis and the Cushing as one of the endocrine manifestation or endocrine
Sorry,
topics.
doctor. I want to add something.
Yeah, sure.
You have to ask about complication of weight gain in your history. One of the complication of obstructive sleep apnea, you ask about headache, you ask about the time of headache. Is it morning headache? Do you have any daytime somnolence? Do you have any snoring during the night? Then you have to ask about carpal tunnel syndrome, the one of complication of this weight gain. You have to ask about any pain in your hand, any pins or needle sensation. On examination, you have to examine also for this carpal tunnel.
Yes. Anything else you want to add?
No,
Okay.
no, doctor. Thank you.
Yeah, thank you, Dr. Ahmed. So as you mentioned, as analysis of the complaint here, you have to know what's the possible common cause of weight gain, how to analyze the weight gain, onset, course, duration, of course, and the progression, is it gradual or sudden? And you can specify a question for weight gain. Where exactly you notice this weight gain? Is it generalized or in the tummy only, or at the back, or at the neck, or any particular area you notice you gain weight in? Okay, the weight, always you ask about the appetite. Don't ask about the weight only. You have to ask also about the appetite. How is your appetite? Because if you have weight gain with loss of appetite, as Dr. Amal said, it's insulinoma. But against this, in this scenario, this patient is hyperglycemic. Insulinoma patient never will be hyperglycemic. He is always hypoglycemic and fainting and dizzy for small or very low effort. Okay, so it's against the differential, Dr. Amal. I don't think you can put insulinoma as a differential because the manifestation of insulinoma is very different. So what you can give as a differential here, as Dr. Ayola gave, I think Cushing on the top and the polycystic ovarian and metabolic syndrome, Dr. Ayola. Don't forget the metabolic syndrome because you have three elements of them: the weight gain, high blood sugar, and hypertension. Okay. Apart from that, the clue or the point or the hint of weight gain in the particular area of the body, it can guide you to the case. In this case, he will tell you, I notice my tummy is bigger than before. I notice my hands bigger than before, getting bigger. My ring size is tight, my shoes. So you will know what exactly can be the reason of his weight gain from his answers. This is what's called the relevant system or analysis of the complaint and the relevant system. Weight gain, you have to ask about the particular area, distribution, I mean, of the weight, the appetite, and the constitutional symptoms. Just rule out any cancer ongoing, which particularly in selenoma, and the endocrinal or endocrinology causes, possibly acromegaly or hypothyroidism. These are the most common in patients: acromegaly, hypothyroidism, and Cushing. Metabolic syndrome, polycystic ovarian. So it will not go out of these. Apart from that, as Dr. Amal said, the failure system or system failure causes heart failure or liver failure or kidney failure. It would be presented differently. So the patient will have leg swelling, more more weak than before, fatigue. But it's not the case here. We have pure endocrine cause. Particularly, there is association with paroxysmal myopathy. So it's commonly will be endocrine cause. The next question, constitutional, we finished the past medical history here. You notice the blood sugar as I'm doing my approach on every case. So you will know that the approach will cover everything. So the past medical history here, as Dr. Ayala, I like here all medical questions. She asked about the medical condition, surgery, allergy, and medication list. Why medication list? And she stressed on that. Any medication you are taking, any medication called steroid, particularly, you have to ask about particularly steroid. When you suspect Cushing, you have to ask about steroid by name. Along with, if you have suspicion of low immunity, you have to ask about steroid by name. Are you taking medication called steroid? Because some patient will hide the steroid as a medication. He will tell you, no, doctor, I just take painkiller. You have taken any medication called steroid? Yes, doctor. For what? For COPD, inhaler, for example. So you have to specify question for steroid, as Dr. Ayola did. The missing point here, when she told you, doctor, I have used creams, You ask her about the name 2 times, but she denied or she said I cannot remember. But ask her for what you are using these creams, right? So she'll tell you, might I have some skin rash. I use this cream for this skin rash. So you might know this is steroid cream. Okay. So don't miss. Even she miss or she denied the medication name or she didn't give you medication name. At least know what the indication or what the use of this medication is. It something for skin rash, which is weird, or medication prescribed by doctor for skin rash. So you have to know what are the indications. Of course, if you don't know the name, if you know the name, it's much great. Okay. Back to the history taking. So you finish the past medical history, and now the time of systemic review. From the head to the toe, you will have finding maybe related to the case. The headache here, as Dr. Amal said, and some doctors wrote also in the chat box, the headache might be related to 3 causes, right? The hypertension itself can cause headache, or the adenoma. If you have Cushing disease, it could be the cause of the headache as adenoma or macroadenoma. And the third cause is obstructive sleep apnea. The patient is not sleeping well and he's awake early or with less sleep, so he'll have headache early, particularly early morning headache. So you have to know what are the nature of this headache. In this scenario, I think it's related to the hypertension. But if macroadenoma, it would be more localized headache. You will have visual field defect. In obstructive sleep apnea, you will have weakness, sleepless sleep, feeling sleepy all over the day. And in this point or in this area, you have to ask about driving. So you have to ask about driving in these conditions, either visual affection due to macroadenoma or obstructive sleep apnea, so the patient is not sleeping well and he's feeling sleepy all the day. Okay, so don't miss the point of driving while whatever or whenever you have problem with the vision or headache related to the vision or obstructive sleep apnea indirect way. So this is the first system to be asked in the systemic review, and you will get headache. You might have vision problem, so it will be visual defect. And the next system will be the thyroid. You have to specify question for the thyroid in this scenario. You have any swelling in front of your neck or intolerance to weather. You have pure endocrine disease, right? It might be hypothyroidism. It might be associated with hypothyroidism, might be Cushing, might be something polyendocrine disease. So you don't miss this question, particularly the thyroid gland. Any swelling or any lump in front of your neck, any intolerance to any weather, which is missed by Dr. Ayola because she got the Cushing, but she missed the question for thyroid. By the way, even during examination, you have to check the neck for any swelling or the neck circumference itself. Okay, this is the next system, which is endocrine. In this scenario, you have to specify questions for every gland: pituitary, thyroid, hair, ovarian for the patient, and pancreas if the question for diabetes. Okay, back to the history taking or systemic review. Chest examination, not chest examination, sorry, a chest question, any short of breath, any cough or noisy breathing. Why? Because this patient might be COPD using inhalers, but not in this patient, of course, but you can ask particularly about noisy breathing, so he might use steroid. The awareness of heartbeat question, chest pain question, you have to ask why for the lipid disturbance. This is metabolic syndrome patient, possibly, so he might have coronary heart disease. You can ask about chest pain, which is one of the most important questions in cardiovascular and systemic review. 2 questions in the cardiovascular you have to ask, unless you have more clear cardiovascular complaint like chest pain, you have to analyze more. But if systemic review, you can ask two questions: chest pain, awareness of heartbeat. If there is possibility to have chest pain, you might relate this or you might link it to the lipid disturbance. Okay, as a metabolic syndrome. Even Cushing, it will lead to the same problem, lipid profile problem. Next system will be the GI. Any difficult swallowing, any change of the bowel habit, any tummy discomfort or tummy distension, which is here possibly you will have some distension, right? So he will tell you, yes, I have noticed some distension in my tummy. You can specify question for the stretch mark. Do you notice stretch mark in your tummy? It's related to this tria and its particular and specific finding of Cushing. Genitourinary or renal system, I don't think there is any change here. Then the ovarian or the female history, any change of 3Ps, period, any change of period, you have to analyze it if there is. Pregnancy, are you pregnant by any chance? You have any kids? And you have to know the last kid age. You didn't ask Dr. Ayul about his or her last kid age. Why? Because it might be panhypopituitarism. Apart from Cushing, it's not as Cushing, it could be as hypothyroidism. So you will know that it's from Sheehan syndrome, postpartum, or as a post cesarean or post delivery. You have to know when exactly she had the last delivery. Is it recent or late or previously? You didn't ask this. Okay, this is the female history, the musculoskeletal, any joint pain. Yes, possibly this patient will have joint pain related to the overweight. And skin rash, here you can say there is possibility of easy bruising or some skin rash. The muscle pain or bone pain, either in the back or any bone pain related to osteoporosis. It could be there, but it's not common. The social, family history, travel history, and do you smoke, do you drink alcohol, do you drive, important for the welfare in this patient, and the job and the impact on the job. I'm trying to repeat the approach in every case to show you that the approach might show you finding or give you a clue about your diagnosis. In every question, you might have finding or pick up the finding related to the case. Apart from this, the questions for the exam, as Dr. Amal asked, the patient presented with, the presentation I mean, then the question for the investigation, you have to give the question or the investigation systematic answer. Okay, try to give it general, specific, and image, and besides image, and the last is invasive. So you can give a specific, and he will ask you for the specific. You can give whatever free urinary cortisol level for 24 hours. Then you can do the confirmatory test. As Dr. Ayula said, you can give the dexamethasone low dose first, then check for ACTH. If ACTH is high, you will suspect adenoma. If low, you can suspect or extra cause related to either paraneoplastic, but it's not the case because the patient is not losing weight. So the cause here is possibly Cushing syndrome. Okay. Any question? Any missing point? We already discussed the options, the management, pharmacological option particularly. Otherwise, the patient will be treated according to the cause. If it is the Cushing disease, so you can refer to the CNS or the nervous neurosurgery, possibly for possible surgery. Sometimes we can do radiotherapy, as Dr. Ayula said. If the cause is related to the medication, so you will refer to endocrinologist and the patient will taper down the medication. Don't stop any medication at any point. If the examiner asks you, would you stop? You can just tell him, I will hold and refer the patient to the assigned team. either to stop it or not. Why? Because you might stop and the stop itself might harm the patient. So don't stop unless you refer the patient to the assigned team. Okay? So the best answer is to hold. Some medication is important to resume it, but maybe with less dose. Some medication, if you stop, it might lead to serious complication like a dystonia crisis, like in this scenario. So you can say, I will refer the patient to the assigned team and they can advise regarding this medication. Okay? Any question? Yes, perfect. So the cuff here will be Dr. Karim. The cuff will exclude lung cancer. Perfect. Lung cancer as paraneoplastic or ACTH related. Okay. ACTH would be what type of cancer with ACTH? Squamous cell or small cell? Who can give me an answer? Dr. Amal, this is your case. Sorry, Dr. Ayula.
Small cell.
ACTH. Yeah, small cell. Perfect. Thank you. Lung cancer, yes. Body gain. Why lung cancer? Yeah.
Small cell cancer secrete not cortisone. I think secrete some hormone.
ACTH.
Yes, some hormone cause زيادة syndrome of
No.
inappropriate
Both of them. It secrete both. Small cell. Remember, always small means small, but it is not small. It's small by size, but it increase or secrete a lot of hormones. So it secrete ACTH and Sayada, antidiuretic hormone, and Lambert-Eaton
Yes,
antibodies, right?
Yes.
So it's small, but it's secrete more. But small cell lung cancer only calcium, right? Sorry, not small. The squamous cell. Sorry, squamous cell. Parathyroid-like hormone. So it increases calcium. Clear? Squamous cell. Small sayada. No. Squamous cell for calcium. Parathyroid hormone related protein. Dr. Ilaf, I think, right? So small will secrete both Sayada and ACTH. Cushing with small. And the squamous will secrete parathyroid related hormone or protein and increase calcium. Remember this. Lambert-Eaton as well with small cell. Any other question or missed point? Dr. Ayula, well done. I believe you tried to follow the approach, right? Even the question of the systemic review, I think it's related to my approach. That's why you didn't miss a lot of things. Any question, Dr. Ayula?
No question. Thank you so much.
Yeah, most welcome. Thank you too. Dr. Amal, any question?
Thank you, Dr. Bas.
Okay, one more question. Last question for Dr. Ayula. If I ask you what image you can offer to this patient, what image?
I was thinking of cranial MRI, pituitary focus.
So you have 3 possible image you can do.
Okay.
Give me for this Cushing disease. What you will do?
In terms of imaging, right?
Yeah, image of a choice in Cushing disease. Cushing disease, the image of Cushing disease. What you will do?
No, it's not coming right now, honestly.
Okay, pituitary. You are looking for pituitary. So pituitary MRI pituitary, right?
Yeah, that was what I said. I said MRI.
Perfect. Okay. For the Cushing syndrome, what you will do?
Cushing's, I'll do the abdominal CT scan of the abdomen.
Perfect. CT adrenal, right? CT adrenals. Okay. If you suspect paraneoplastic or
CT chest.
perfect CT chest, or starting even by chest X-ray, then CT chest, looking for lung cancer.
Lung cancer.
Is it? Yeah.
Yes.
Okay. Possibly, if there is lung cancer or mass, you can give option of invasive test, so you can do endoscopy or bronchoscopy. Okay.
Okay.
Any question?
No.
Okay, Dr. Amal, any question?
No, Dr. Bassem, Jazakallah khair.
إياكم يا رب. جزاكم الله خير. Any question from others? I hope I didn't miss a lot of comments. Obstructive sleep apnea, we already mentioned. Stretch mark, metabolic syndrome as differential, perfect, yes. For the previous case, I think we discover most of these comments. I have read most of these comments. Anyone has comment, feel free to comment now. Any question? Any missed point? Any suggestion? Any doubt?
Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh.
Thank you so much for
In
your time.
the
Okay.
beginning of weight gain analysis, also to ask about changing diet and exercise.
Yeah, we mentioned the diet or the appetite. Yeah, you mean, yeah, for less exercise? Okay. Yes, okay.
Less exercise and if you change in diet.
Okay. So, yes, it's related, but it's not conclusive, right? So if even a change of the diet, what can you suspect? Hello?
Yes, I
Doctor?
mean as part of the analysis in the start
Okay.
of the analysis of weight
Yes,
gain.
but the most
Just as
important.
the
Yes, I
general
agree.
question.
I agree. But the appetite here is important than the diet,
Yes,
right?
appetite is important also.
Yeah.
Yes.
Yeah, we add also for the appetite, loss of appetite, you can suspect lung cancer, by the way. So it's
Yes.
either insulinoma or lung cancer causing ACTH-related adenoma or cancer, right?
Yes.
Okay, thank you anyway for your comment, Doctor. Dr. Huda, right?
Hanadi.
Hanadi. Thank you, Dr. Hanadi. Thank you so much. Anyone want to add any comment else? Feel free, please. It's a meeting for discussion, not only participation. Always my advice is you can gain a lot of confidence while you are commenting verbally, not only with the chat box. So the written comment, okay, yes, you can add information, but you will not gain confidence. You gain confidence with comment. So feel free to comment. It's a meeting for all. Okay, so I can
Yeah, I was just sorry that Dr. Bassem is
Yes,
highlighting. I was just
sure.
looking at things that I've missed during this history taking. I think I didn't ask about acne, which might be important. The libido of this patient, I think it might also be important as well, isn't it?
Yeah, sure. Particularly in the male patient. Yes. Yeah, for the female polycystic ovarian, yes, you have to look for acne and Cushing as well. And the hair, yeah, the hair also, we didn't mention the hair. The hair distribution, yes, you're right. For the Cushing as well, it can lead to. So the hair distribution in the face can be increased with polycystic ovarian, right? So you can suspect or you can put it as a differential, as well as for the acne. Perfect point. Thank you, Dr. Ayula. But the female history also is very important. Okay? Female history, pregnancy and period, and birth control pills. You have to ask all these questions. Clear? Stretch mark as well is very important question in the history taking. Once you suspect Cushing, you have to ask this question. And the question for steroid as drug induced. Medication history. Clear for all? Anyone want to add comment, please feel free. Otherwise, we will end the session. So satisfied all? Okay, thank you everyone. Thank you for everyone even wrote in the chat box. and I hope I read all the comments. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام ورحمة الله وبركاته.
Good night, everyone.
Good night.